Today's lecture is going to be on anger, hostility, and aggression. Our objectives is not only to discuss these three aspects, but we're going to be looking at psychiatric disorders associated with them, signs and symptoms of behaviors, looking at nursing interventions, and then describing important issues that we as nurses have to be aware of when we're caring for patients who suffer from anger, hostility, and aggression. So let's define anger. Anger is an emotional response based on frustration of desires or a threat to one's need, either emotionally or physically, or if they feel challenged. With aggression, it is actions or behaviors that result in a verbal or physical attack. Some comorbidities that go along with anger and aggression include PTSD, substance abuse disorder, and can coexist with depression, anxiety, psychosis, and personality disorder. With de-escalation, we talked about this before, but I think especially with making sure that we're understanding it, we have a goal when it comes to dealing with patients who have really strong emotions that can lead to violent behavior, that we engage in de-escalation. So verbal de-escalation is how we communicate, or things that we do when there's a potential for danger or if someone's threatening. And it's really used to just try to prevent a person from causing harm to us, themselves, or others. So just remember that each facility has its own training, but we should never using physical force as the first. There are some facilities that do have some type of training, maybe evade with that, but just know that if you're very cautious of your patients, most of the time you can perceive that there's a problem before it gets to this point. But if it doesn't, try to talk them down, try to use another resort. So when you're using de-escalation, certain tactics have to be used, and you have to have help from staff in order for this to work. Two concepts to remember when it comes to de-escalation. That when it comes to an angry person, you can't reason with them. So the only goal, objective that you have in de-escalation is to reduce the agitation until that point that you can actually engage in a conversation. You have to remember that with individuals who are at the point of being angry or aggressive, they range anywhere from that severe to panic when it comes to anxiety. And so therefore the potential for them to not remember, or the fact that the expectation that you're going to engage in a conversation, that's not going to happen. And so your goal is to return a patient back to a calm state before you can begin to discuss why they might be angry. And de-escalation techniques, it's something that has to be practiced often, because the natural response for humans is not to want to de-escalate. It wants to engage in fight or flight reflexes. So we have to make sure that we're always calm, centered, and that we're professional. Factors that can cause crisis, though, may be that individual feeling a loss of personal power, or it's an attempt to maintain some sense of self-esteem. It could be out of fear or failure, seeking attention, or having displaced anger, or some type of psychological or physiological cause. Signs and symptoms that you're going to see include raised voices along with speech, high-pitched voices, fidgeting, shaking, having a balled fist, erratic movements while gesturing, pacing, or aggressive posture. So what do you need to be doing? Well, one, in order to be at a point or a position to be able to engage someone in de-escalation, you have to be observant. So having control over your own nonverbal behavior, including your breathing, your voice, your volume, your tone, making sure you're having the correct body language and using the correct vocabulary. If you're calm, you can just about gear or expect that your patient is going to be calm as well. Other nonverbal cues include not only appearing calm and assured of yourself, but also making sure you're in the proper location, making limited eye contact, controlling your facial expressions, being alert, keeping your hands to yourself, speaking solemnly or soothingly, and then making sure that you're positioning yourself for safety. So you always want to make sure that the patient is not in between you and the entrance to the door, just in case you have to get away. Pointing fingers can have an accusatory feeling or can cause someone to feel threatened. Shoulder shrugging can mean you really don't care. Rigid walking can be unyielding or challenging. If their jaw is set with their teeth clenched, they may not be at a point to have an open mind about the conversation. A natural smile is good, but if you have a fake smile, it can really definitely cause this situation to be have more tension. And then make sure your movements are slow and deliberate, because if they're really quick, your actions could be misconstrued. When it comes to personal space, invasion or encroachment on a person's space can cause anxiety. You should have at least 1.5 to 3 feet or far enough that that individual can't hit or kick you. And don't touch anyone who's in a hostile position, because that can be seen as being aggressive. And if you keep your hands visible at all times, it prevents the individual from seeing your actions as a threat. Positioning yourself for safety means being at eye level, staying at the same height. Angle yourself 45 degrees to the individual. Make sure that you maintain distance. Keep the exit clear. Always face the person. A little bit more than we talk about their legs length away so that they can't hit or kick you. And stay far enough away from that person that they can't hit, kick, or grab you. When you're looking from a verbal sense, you have to maintain your focus to be calm. Use soft, slow, low tones. Don't interrupt the individual. Don't get defensive. Respond selectively and be honest. Empathy. Remember that empathy implies that you as an individual are talking about the patient's feelings. So to be empathetic, you always have to acknowledge that other person's feelings. They cannot have anything to do with yours. So if the statement says, which statement by the nurse would be empathetic, your response should be about that person's feelings. Don't analyze emotions. Do not attempt to argue or persuade. And identify any external controls as institutional. Simple listening skills listening actively with silence, nodding your head that says you understand, not interrupting to make sure that you're getting the full information, and allow them to vent. 3 main listening skills. We talked about therapeutic, but attending, making sure that your physical and mental attention is on that individual. Engage them to use eye-to-eye contact, but don't do it too long. Know that if you use like nodding your head or saying okay or ask questions, says that you're trying to be involved. Reflecting requires that you paraphrase and reflect using someone else's feelings, and that's about empathy. And when you're listening, really listening, make sure there's no other activities or is interfering with the time that you have with that patient. Don't multitask. Be present in the moment and actively listen. So when you're actively listening, some statements might be I statements, open-ended questions, mirroring, paraphrasing, and don't forget to be cautious of your body language. With responsive listening skills, you engage in acknowledging, apologizing, agreeing, being inviting criticism. I was going to say be able to invite criticism. And most importantly, it's your tone of voice. Your tone of voice goes a long way in conversations and de-escalating. Empathetic listening requires that we not be judgmental and that we don't ignore or pretend to be paying attention to someone. We're listening to what they really have to say. We're restating it, clarifying it, repeating it, and being empathetic about it, and then we validate. And as a result, all together, but sometimes maybe not, but we want to try to establish rapport with the other person. Pay attention to your tone, your volume, your rate of speech, and the inflection of your voice. Stages of aggression include triggering, the escalation, the crisis, recovery, and post-crisis. So again, remaining calm, avoid overacting, validate. For instance, I understand why you might be upset. Remove onlookers, relocate them to a safe place, watch for nonverbal cues or threat, bring in another trained person to assist, because there is less of a chance that the patient will become too aggressive, especially if one is there as a presence and the other one there is just talking to the patient. It is not until the person has calmed down that we can begin to address any individual situations that may be bothering or plaguing the interaction at that time. We need to make sure that the person is working on their own situation, or working on making sure that the person that's working with you doesn't derail basically your ability to de-escalate the situation. And trust your instincts. If it's not working, just stop, close the conversation, and notify the staff for the situation. What not to do is important. You want to make sure that you're not avoid becoming emotionally involved, avoid engaging in power struggles, avoid becoming rigid in your process, avoid telling the other person that you know how he or she feels, avoid raising your voice or cussing or making threats and giving ultimatums or demands, avoid aggressive language, including body language, And just don't attempt to intimidate a hostile person. So we have a case study. What are some risk factors that may predict violent behavior? Well, a history of violence is the single best predictor of future violence. What are some ways nursing staff can keep safe while attempting to de-escalate an angry client? Well, sometimes you're going to have patients who are delusional, hyperactive, impulsive, or are predisposed to irritability. And these ones are at a higher risk. But we want to make sure that we assess for risk of violence, asking ourselves, does the patient have a wish or intent to harm? Does the patient have a plan? Does the patient have means available to carry out the plan? And does the patient have certain demographic factors that put them at risk? C says a client has become violent and requires restraints to ensure your safety as well as that of the milieu. What questions should be asked when you need to restrain a client occurs? Well, there's so many things that can be done. But most of all, one of the things we want to make sure that we do is ask, could we have done anything that would have prevented the violence? If yes, then what could have been done and why was it not done in the situation? Did the team respond as a team? And if not, why? How do staff members feel about this patient, about the situation? All those are things that we need to take into consideration. Is there a need for additional staff? How did the actual restraining process go? And so there's a lot in my notes. Just please make sure that you read over them. And for the most part, this is the end of our lecture.